Okay, so what we're going to do is basically rotate head on neck. Okay, so go ahead and lie on your back for me. So for OA PIVM, I'm going to think about yes, and I'm going to think about maybe. Okay? So to do yes, is yes the first one we have? Yeah. To do yes, what I want to make sure that I'm doing is that I'm going to not do flexion of the whole neck. So I'm not taking this head and doing this, right? I'm pretending, like you see that X there, that there's an axis through their ear. So literally in my head, I'm thinking there's a pole through Ben's ears. Okay? And I'm trying to move his head around that pole. Okay, so I'm going to try to flex his head on his neck. So I'm looking at suboccipital motion into flexion, and then I can do the same thing right away into extension with that same axis. Okay? So for flexion, I'm going to take my thumbs and put them on his zygomatic arches. Right? Put them on his cheekbones. Okay? I'm in this position here. I have that on his cheekbones, and literally this is the motion that I'm talking about. It's as if he's nodding yes, but it's a really tiny nod. See, my thumbs on his zygomatic arch are what's producing the motion. So I'm just kind of bringing his chin down, I'm just nodding his head. And I'm getting a sense for how much freedom of motion he has, if he has symptoms. Sometimes I might like side bend him a little and flex him, or side bend him this way and flex him, and see if I can kind of maybe isolate one side versus another. But you're just getting an idea for the amount of motion and what it feels like at end range. Then extension is the exact same thing. With extension, what you have to be sure of is that you're coming in more vertically when I grab his head. Because when I extend him, I'm going to have to radially deviate. And if I'm already here, then it influences my ability to do that. So I want to make sure that I'm coming in more directly overhead. So when I look at extension, backward bending now, I'm kind of doing it like this. As opposed to here where I don't have as much freedom of motion because of my wrists. Okay? So the key is, and the common mistake, is that we flex and then we keep going. You know, we're like OA, but then we're like 1, 2, 3, 4, 5. Right? So again, it's just head on neck. Think about how little bit of motion that head on neck is. If you palpate your own C2 and flex, and see when motion stops. If I keep going, you know, even as far as there, I already now have motion in my mid-cervical spine. So we're trying to isolate it to suboccipital only. Another way I can do it, if we're not sure or comfortable, sometimes I might choose one or the other of these, is I can do a side bending one. Remember, OA is also our maybe joint. So in this case, the axis is through Ben's nose. And now what I'm trying to do is move that head around that axis. So here's what I'm not doing. I'm not taking Ben and going, right? I'm not moving him into side bending. Here's what I'm doing. See how that's head on neck? And you guys see how much better that moves? That's really good. This, right there I have R1. And there, it's not moving much more than that. So that's tight that way. This way feels really good. This way feels really tight. So imagine my patient Adam doing some OA when I was doing those on him. Imagine what I would have found with him. You know, here's this guy who's side bent a little bit to the left to start. If you imagine trying to do a side bending to the right with him, it would have been like running into a wall. And that would have confirmed what we saw actively. Right? So this is a way to confirm what we're already thinking from our active range. We're not relying only on this. For assessing motion, with these, I think you'll be able to feel the differences, some of the differences in the motion a little bit better than maybe the last ones. Okay, so the PIVM for OA is that, and the PIVM for AA is the best thing known to man. This is the easiest one, and it's probably the most reliable one because it's easy to do, and it's very easy to kind of quantify. So if I want to look at AA PAVM, what motion is available at AA? Rotation. So how do I cause rotation at AA without causing rotation everywhere else? I would do this. I would flex him all the way up here. Because what I've done by flexing his cervical spine is I've locked out these lower cervical joints. And now, when I produce rotation, all of this rotation, primarily, is coming from AA. And I can look easily and see how far does his chin go that way, and compare it with how far does his chin go this way. Ooh. Not so good, right? Limited there. You guys see that difference? That's as far as Ben can go that way. See how much further he can go that way? So it's easy to quantify. I mean, I can see this very clearly. I'm not worried about palpating segmental I'm flexing him all the way up as far as he can, chin on chest, whatever they can tolerate, and then I'm just rotating his head. And you know, that's a way to look at AA motion as well, actively. Sometimes I'll have patients flex like this and rotate one direction. Earhart calls it the two-finger exercise, or he'll have them come down and have two-finger separation between their chin and their chest, and then he'll, from that position, he'll have them work. So Ben, for example, I would send him home doing this exercise, where I'd have him turn to the side, maybe even give it a little overpressure, right, where he's flexed and he's rotating head. All of this is coming from AA, because I've locked down the lower segments. So I'm trying to focus and zero in suboccipitally. That one's pretty easy. You guys will like that. You'll be able to see differences from side to side. All right, so we have OA forward bending, backward bending, axis through the ears. OA side bending, axis through the nose. And then we have AA, we flex them all the way up and just rotate. The other OA, we're not going to concentrate as much on. It's there, but we're not going to focus as much on that. The suboccipital, the OA lateral glide. I think it's hard to feel that. We've played with that in kinesiology, if you remember, feeling the C1 lateral mass. But we're going to just focus on the ones I just showed you. Okay, so we're done with our pivot, right? If it's mid-cervical, it's up glide, down glide. If it's suboccipital, it's flex and rotate for AA, or it's rotate, backward bend, side bend around that axis for OA. And we've kind of completed our pivot testing.